Welcome back. When you arrive to a seizure call, don't get hypnotized by the shaking. Your first job is not to diagnose epilepsy. Your first job is to protect oxygenation and prevent a second injury. Because in the field, a seizure kills in two main ways: airway compromise and time. A convulsion that stops quickly is often survivable. A convulsion that doesn't stop becomes a physiologic fire. Rising oxygen demand, impaired ventilation, acidosis, hyperthermia, and a brain that starts injuring itself. So the opening question is simple. Is this an active seizure right now? Or are we already in the post-ictal phase? And everything you do next flows from that. A generalized tonic-clonic seizure is not just electrical noise. It's the whole-body stress response. Muscle activity drives oxygen consumption, ventilation becomes ineffective, CO2 rises, the patient becomes acidotic, and secretions pool, right when protective reflexes are gone. That's why aspiration is a real complication, not a theoretical one. That's why positioning and suction are not just nursing steps. They're resuscitation. And that's why time is the enemy. Most seizures stop within about 5 minutes. But if you cross that line, the likelihood of ongoing seizures and recurrence rises, and the patient can spiral. So we treat early, but we treat with discipline. If the patient is actively convulsing, don't fight the limbs. Don't restrain. You win this call by controlling the environment. You clear hazards, protect the head, and get ready for airway control. Then you put the patient on their side as soon as you safely can, because that single move reduces aspiration risk immediately. Suction becomes a priority, not an afterthought. And you position the head in the way that supports the airway. Think simple, effective alignment. The goal is one thing: keep the airway patent while the brain is misfiring. Seizing patients often desaturate, sometimes from true hypoventilation, sometimes from secretions, sometimes for apnea after benzodiazepines. So you give oxygen early, but you give it with a target. Keep saturation around 94 to 99%. That range is practical, high enough to protect the brain, but still anchored in real physiology, instead of reflexively say, I go to 100% at all costs. And while oxygen is running, you're already preparing for the next decision. Do we need medication to stop the seizure? Here's the operational definition that matters. If the seizure is continuing, or you're seeing repeated seizure without full recovery, you should treat it like status epilepticus physiology. Because once you pass that early window, you're not just watching a seizure. You're watching a process that can destabilize airway, ventilation, and circulation. So we don't do hope-based medicine. We stop the seizure. And for us in the field, that means midazolam, or dormicum, with clean dosing and clean reassessment. Midazolam is your seizure stopper, but it's also a respiratory depressant. So the mindset is stop the seizure, then immediately recheck breathing. So per the protocol, we use 5 milligrams IV or 10 milligrams IM or 10 milligrams IN. Then you reassess. And if the seizure continues, we can repeat the dose after 5 to 10 minutes. And remember, midazolam can drop blood pressure. So if hypotension appears, treat the physiology. Small, reassessed crystalloid boluses, while you keep trending perfusion and ventilation. And also, there's a safety rule backed into the good practice. After you give dormicum, your airway vigilance goes up, not down. This is where teams either look professional or look surprised. Sometimes the seizure stops, and the patient looks worse. Not because you harmed them, but because now the muscles are quiet, and you're seeing the truth. They're apneic, abstracted, or drowning in secretions. So the moment the convulsion ends, you do fast, clean recheck. Chest rise, air movement, SpO2 trend, and if you have it, capnography trend. If ventilation is failing, you do not wait for them to wake up. You support ventilation. A seizure can be the symptom, not the disease. Hypoglycemia is one of the most dangerous, simple fixes in the field because it can keep triggering seizures and brain injury until you correct it. So you check glucose early. And if glucose is below 16 mg to deciliter, the protocol is clear. Give IV glucose, 25 grams, using 25% solution, then recheck. If after 5 minutes the glucose is still low, you give an additional dose, half of the initial dose, and reassess again. This isn't optional care. This is brain-saving medicine. So, as we already said, after dormicum, you must follow blood pressure, especially if the patient is already borderline. Benzos can drop tone and worsen hypotension. And if the patient is dehydrated, septic, or bleeding, you can unmask shock. So you trend blood pressure and watch perfusion. You don't get distracted by the seizure stopped and miss the physiology underneath. This is where the call turns from seizure management into full patient management. Once the patient is no longer actively convulsing, the next job is to decide, is this a typical post-ictal recovery or is something else wrong? Post-ictal patients can be confused, agitated, sleepy, even combative. That can be normal. But red flags are different. Persistent focal deficit, persistent severity, depressed consciousness, signs of head trauma, meningismus or suspicion for CNS infection, or a story that screams toxic or metabolic. So you zoom out. This is where you ask the questions that actually change the outcomes. This isn't an interview. It's a focused search for causes that change management. You're asking targeted questions. Is there a non-seizure disorder? Missed doses or new medications? Any fever or recent illness? Diabetes or risk for hypoglycemia? And head trauma. Did the patient fall because of the seizure or prior? Any stroke-like symptoms before the event or a new neurologic deficit after? And one that's often missed. Pregnancy or the postpartum period, because eclampsia can occur up to 8 weeks after delivery. And missing it means missing a high-risk diagnosis. Your exam has 3 lanes: airway and breathing, that means secretions, obstruction, aspiration signs; neuro, a GCS trend, pupils and focal deficits; trauma, thumb injury is common, but head injury and bleeding can be the real danger. And here's practical warning. You should not insert objects into the mouth. You protect, you suction, you ventilate if needed. Now comes the fork. Does the patient need advanced airway? Yes or no? If there is growing airway compromise, inability to maintain oxygenation or ventilation, repeated seizures, or a patient who cannot protect the airway, you transition. At that point, you make a clear pivot. Airway management becomes the priority. And if not, you keep monitoring. Keep the patient lateral, keep suction ready, and actively prevent aspiration while you transport. The key is not being passive. It's making an explicit decision. A high-level seizure call is not, we gave dormicum. A high-level seizure call is this. You protected the airway early, stopped the seizure quickly, corrected reversible causes, and prevented secondary injury. So the mental model is simple. Control the environment, position and suction, Oxygen to 94 up to 99%. Dormicum by the best available route, 5 mg IV or 10 mg IM or 10 mg IN. Repeat after 5 to 10 minutes if needed. Check glucose. If it's below 60, give 25 grams IV. Reassess and repeat if needed. Trend blood pressure and perfusion. Decide on airway management early and act if needed. Transport with continuous reassessment and a clean handoff. If you carry one line into the field, make it this. Stopping the seizure is step 1. Protecting the airway is what keeps the patient alive. Thanks for listening.